Um, but our first speaker today that I wanted to is a really good friend that I got to know over my 6 years with Perfusion.com. His name, and I always screw up his last name, but I'll say Akram Zaaqoq, and he'll help me with that later on. But he's an associate professor of medicine at the critical care medicine department at Georgetown University. Broad clinical experience caring for critically ill surgical patients with emphasis on mechanical circulatory support devices and ECMO. The societies he's involved in include ELSO, the SCCM, ASIO, and STS. And he was a consultant with our group when I was with Perfusion.com. You know what? Go ahead and set that up, please, however you get out of your way. COVID-19 pandemic experience and what we have learned. We all went through some once-in-a-lifetime experiences, especially if you were involved with ECMO. As clinicians, there was a lot of burnout. We were once heroes, and then we were considered demonic people when the geopolitical phases of it all fell in. So we went from the extremes to the highs to the very, very lows. So Akram is going to maybe approach that as far as from the emotional standpoint, what we went through, and also what else we learned through this pandemic. Akram, great to have you.
Thank you very much. Good morning, everyone. It's good to be here. Thank you, Bill. And thank you, Susan, and the organizing committee for inviting me to speak about COVID-19. Right, excellent. So probably some of you wondering why we're speaking about COVID-19 since it's over. And we have learned a lot throughout the pandemic. And there is a lot to catch on, and there is a lot of work going on in that field. So these are my disclosure. It's not an experience until we live it in reality. I would like to dedicate this session to the COVID critical care, which is a group of researchers all over the globe. They came together during the pandemic when there was a lot of uncertainty, and they produced a lot of science during that time. So these are the objectives for my talk. So by December 2019, as you can see, the COVID-19 pandemic erupted throughout the world. And when you look at the WHO website, you will find it's more than 700 million people actually were affected by the virus. And the mortality was close to or more than 6 million people all over the world. Okay, so here is the thing. The COVID-19 is a pandemic that's probably is going to happen again. Because if you look at this chart, you can see that the COVID-19 was actually the third outbreak of the coronavirus in the modern time. So there was the one that was in 2002, and the other one with the MERS outbreak was in 2012. Now, we didn't see the impact of those outbreaks because it was contained and also in certain regions, but also the virus at that time had a high fatality, which means a lot of people actually died before they made it to the hospital. So the coronavirus had this like perfect balance between getting people really sick, but they don't die, so they end up in the hospitals. Now, this is not the worst. Actually, the worst pandemic we've seen was the H1N1, and not the recent H1N1 in 2008, 2009. It was the one in 1918. This one affected close to 500 million people. Now, 500 million people sounds like less than what we have, but at that time, that was the third of number of people on Earth. And the fatality or the mortality was close to 100. So it was also very significant. So the point I'm trying to make from this chart, that we've been through this pandemic, but probably it's going to happen again and will keep happening. So it's useful to look at what we've learned during that time, or during our time, and hopefully we can do better in the next time we see a pandemic like this. Okay, So the virus, the coronavirus, and as most of you know, it's a virus has S protein spikes that get attached to ACE receptors on the cells, especially in the lungs and other organs that get attached to. Now, once the virus gets inside the cell, induces a degree of inflammation. And if you think about it, any of us who get injured, like a wound, immediately will have like, redness, hot and tenderness. So this happens on a larger scale. It happens inside the lungs, and the lungs is by itself, it's very sensitive organ. Meaning once the inflammation started, it becomes very intense inflammation. The whole purpose of the inflammation is to contain the infection, contain the virus, and keep us alive. But once the inflammation comes out of control, start disrupting other mechanisms inside the body, meaning such as the coagulation system, and then you will see there is an impairment in the normal lung function, but also there is the clot and thrombosis that we start seeing in the coronavirus. So it's a severe infection and severe inflammation. And then once the virus starts and this inflammation start spreading beyond the lung or spill out in the system, start affecting the other organ systems. So from the clinical description, it goes into phases. So we have the first, after the incubation period of the virus and the viremia, which most of the time is asymptomatic, this intense inflammation goes into phase 1, 2, and 3. So phase 1 is where you will see the normal symptoms that we all like seeing, the fever, the cough, and then afterwards, start spreading into the lung and affect the lung in a way that goes what we used to call like L type and H type, of the lung. And then phase 3, where there is the multi-organ dysfunction that happens on those patients. Now, there was a lot of talk and discussion early on in the pandemic when we started discussing, it's like, are we dealing with ARDS? Are we dealing with some sort of other ARDS? In my opinion, it's the same thing. It is different stages of the inflammation of the lung that goes from a lung that is not able to perform gas exchange, but yet very compliant, and it moves easily, to a lung that is not able to perform gas exchange, but yet is very stiff. So it depends where you see the patient during which phase, that's which type you're going to see. But it just tells you the degree of, uncertainty that we've seen early in the pandemic. And then there was the discussion about, okay, what about if we proning patients while they are not intubated? And actually it turned to be something useful. Proning patients, especially early on, it has, as you can see on the left-hand side, it has actually some benefit, meaning might decrease the mortality of the patients. But also it might decrease the work of breathing. It might decrease the rate of intubation early on those patients population. And afterwards, we talked about, okay, what about if we do not intubate those patients early on? Let's just wait on them. And it turned to be not very useful strategy if the patient need to be intubated. I think we all learned that we should just intubate them and place them on mechanical ventilation. So this study is actually from Spain, and has close to 3,000 patients included. There was no difference between early intubation, meaning patients get intubated within 24 hours of their symptoms, or of their presentation to the ICU, versus late. But then when they did matching to the patient, meaning getting the patients all have the same characteristics and baseline comorbidities, it turned to be actually early intubation is useful, and delaying intubation has a higher mortality rate on those patients. And even they go about what they found during the waves of COVID, you're all aware, the waves of COVID was in different parts of the world, is not matching. During the waves, they found that actually the clinician start understanding that, and there is the trend towards intubating patients early on if they needed to be intubated. And then, as you all know and aware, that there is evolution of the medication that we use during COVID treatment. And in this chart, you will see whatever in dark blue that was actually proven to be effective with a randomized controlled trial. And in the light blue, it's mainly by just observational studies. But yet, this is very important because as we dive deeper into the ECMO world, you're going to see that has an impact. And it took us almost like a year after the eruption of the virus or the outbreak of the virus, actually to have the vaccines. And the vaccines was approved by FDA, and it turned to be effective. Okay, I'm going to spend whatever remaining of my talk to talk about ECMO, since you guys all ECMO specialist and perfusionist, because this is very fascinating area. We've done a lot of work in it. So the first report, and I'm not going to go into the earlier reports that came out from China that didn't show a good outcome. So this is the first report that came out from the ELSO registry, and that was published in the Lancet in September 2020. So the 90 days mortality was less than 40%. But when they did the modeling, they found the patients who has temporary circulatory support, meaning they were started on some sort of VE ECMO, have significant increase in the mortality. And also they found the increase of age was not associated with good outcome. And if you put the patient on early if they have like high PF ratio, also was associated with lower mortality. So that was a good thing if you put them on ECMO relatively early. And then the other comorbidities, such as the acute renal failure, immunocompromised state, chronic respiratory failure, these are associated with poor outcome. There was no effect of the center volume, meaning if the patient, if the center has high, early on if the center has a high experience, it didn't really differentiate that much early on in that phase. But then there was a subsequent report also came from ELSO, and that included close to 350 centers from 41 countries. And they compared early wave and second or early placement on ECMO versus late, adaptation of ECMO. And they found decrease in the outcome, meaning the mortality went from, at 90 days, mortality went from 36%, went up to 51 or 59%. And we're not sure why this happened. But if you put it in the context of what I mentioned before, meaning the patient immunocompromised state, the use of the immunosuppression, they found there is a higher rate of co-infection in the lungs, and subsequently that also, contributed to the outcome and the prolonged run of ECMO. And also the delay of intubation and the use of non-invasive mechanical ventilation for a longer period of time. So the immunocompromised state, the use of the immunomodulator predisposed the lung to infection. But the use of non-invasive mechanical ventilation was a little bit also tricky, because if you remember, we had patients on BiPAP machines, actually they having like very aggressive deep breathing. And that contributed to worsening of the underlying lung condition and make it more like inflamed. This report came from Germany, and included 673 patients. The ICU survival in the overall cohort was close to 31.4%. The survival, the same observation, was lower during the second wave of the pandemic, but they included that using the EOLIA trial criteria was actually associated with good outcome, and the EOLIA trial criteria, it depends on the PF ratio. If it's less than 80, for almost 6 hours, the patient should be supported by ECMO on mechanical ventilation, of course, and after proning, they should be supported by ECMO. Subsequently, there was this matching study was done in UK, and what they found in this report, it was multi-center, and they get a patient who are ECMO and patients who could be an ECMO candidate, but they did not end up on ECMO. And they found the patient who are ECMO candidate, they did not end up on ECMO, had a higher mortality. So actually ECMO was turned to be useful intervention, rescue intervention for selected patients. Okay, so this is a comparative analysis study. Martin Ermer from Toronto with Edifan, they conducted that study. And what they did, they tried to mimic the randomized controlled trial and try to assign patients, either, end up on ECMO, and what if they don't end up on ECMO. And it turned to be patients, if they are less than 65 old, and the PF ratio less than 80, and their driving pressure, which is a measure that we use in the mechanical ventilation, higher than 15 during the first 10 days of mechanical ventilation, they will benefit the most from being placed on ECMO. So as you can see, like during the pandemic, the messages when start coming to ECMO, it start becoming literally what we know, that ECMO is like, useful intervention if it's done in the appropriate patients and done early on. And of course, with experienced caretaker and, experienced centers. Okay. So, afterwards we said, okay, let's even push the edge a little bit and try to understand if there is something we can do different, since this is like, a pandemic, there is a large volume of patients getting placed on ECMO, is the management can be changed. So we talked about, what about proning patients on ECMO? And I'm not sure how many of you actually do it in your institution. And turned to be, it's appropriate intervention, in this study shows it's associated with good outcome and good survival, for the VV ECMO patients with severe ARDS. Now, will come with some caveat, because, if you're going to prone a patient on ECMO, that means you have to keep them sedated. And, it's require, as you all can tell, is going to be like very resource, intensive intervention. And there are some risk associated with it. So it needs to be like, there is infrastructure for it. And also, what's actually the benefit of the patient? They will survive, but what's the long-term outcome benefit for proning? And speaking of which, there is a session in ECMO meeting, maybe next week, and you're all welcome to discuss that. Okay, once you put a patient on ECMO, how fast do you drop the CO2 on those patients? What about the oxygenation? Do you want to see like, PO2 of like 100? So that was very interesting also. Is it dropping the CO2 too fast? Is that detrimental for the patient? And it turned to be yes. If you drop the CO2 too fast for the patient, you predisposed to impairment of the cerebral autoregulation. And that is by itself can predispose the patient to have stroke and bleeding. Now, this is a whole another area. So if the patient has any stroke or bleeding, mainly hemorrhagic stroke, I mean, how many of our centers actually intervene on those patients? Like, my center, for example, if I call neurosurgery to come to look at any of those ECMO patients, they will laugh at me and they walk away. They don't want to touch the patient. So being very, conscious about how fast to drop the CO2. We know with ECMO, we all can, make the CO2 almost zero, but how fast we drop it and over how long. In this study was 48 hours. So like dropping too fast within 48 hours of ECMO initiation, it could be detrimental. Hemorrhage and thrombosis was a big areas of also concern. How to manage anticoagulation during the VV ECMO was an area of debate. Should we use heparin? Should we use bivalirudin or any other anticoagulants like argatroban? Should we anticoagulate this patient? Should we not anticoagulate those patients? Should we use antiplatelet therapy? I cannot give you the answer for that because I don't know the answer. But this study shows actually bleeding was more common than thrombosis in the ECMO in those patients, and especially in the ECMO patient, bleeding was very common. And when they patient bleed, and bleeding can be either like central or most commonly from GI, is also associated with poor outcome. So being conservative with anticoagulation probably will be the right thing to do for those patients, or not anticoagulate them at all might be appropriate. Okay, we learned about the right ventricle in the COVID-19. And there is going to be a whole session about right ventricle, but because of this arrangement within the lung is connected to the heart, as you guys see it all the time, and then the heart, especially the right side, start failing when the lung vasculature start becoming narrower, and there is clots, in these vasculature, similar to what you see with the PE. But on top of that, those patients, they are not oxygenated well, they have high CO2. It's like everything you manage on the bypass. And then they are on the mechanical ventilation, which is also has some detrimental effect on the RV. So RV start failing, especially in the long ECMO run. So that was one of the observations we've seen in the pandemic. And that's why, we look at this study that came from Rush University early on, also in the pandemic, when they used the Protec Duo cannula, for VV ECMO support. They did not just use it; they used it, and also they woke up all their patients, and they get them up and mobile, and they have very good outcome. So that brings me back, to the proning patients on ECMO. Is it like, proning patient ECMO is the best strategy, or just cannulate them and wake them up? And when you cannulate them, which cannulation strategy is better than the other? In my observation, my opinion, I would say, as long as you pay attention to the RV, doesn't matter which cannulation, has superiority. But the issue with a clinician early on, they didn't pay attention to the RV at all early on. So then that's why, all of a sudden, you have a COVID patient on ECMO, they were doing well, and then they crash, and you don't know what happened. It's probably the RV just, gave up. Okay, if the patient survived, they have good outcome, and that came from Europe. If they survive, a good portion of them actually go back to work. The most common symptom they will have is a little bit of dyspnea. They don't require a lot of oxygen, afterwards. So once they survive ECMO, they have really good outcome. Okay, so the observation was, during the pandemic, we had differences in the mortality over time. We had a longer ECMO run in comparison with the other ERDS. There was, risk for thrombosis and bleeding. And also the immunosuppression, we're not sure how much that actually affected, the outcome for the ECMO patients. And then the RV failure, those are the observation. So what can we do next time? And if we have a pandemic, definitely resources is going to be a big thing. Always resources during any pandemic is a big, and the burnout and staff burnout, and we all been through this, and you see how much people were stressed during the pandemic. So definitely it has to be a tier system within all the institutions, and maybe in different regions, or different states. For instance, in Phoenix, in Arizona, they had a whole one number for all the ECMO system there. So maybe that's something, and also it happens in Minnesota, I think. So, maybe a system like this will be very useful, where you can distribute a patient where they need to be located. Of course, paying attention to the staff is the most important thing. And who will benefit, or how do you benefit the most patients? To benefit the most patients, you need to cut down on the ECMO capacity so you can accommodate more ICU patients and put them on mechanical ventilation. This is, definitely a reasonable thing to do. So you don't have really to over ECMO for everyone. And what we've learned the most is actually people getting together and meetings and talking to each other and learning from each other experiences is very useful. So as you can see, when the pandemic comes, it comes with challenges, but also comes with opportunities. And the opportunities that we had opportunities to push knowledge more and do things that we do, even better. So it has to be a mechanism where, or the societies has to take on the responsibility to set priorities also during the pandemic to advance knowledge. And that's the last slide for me. And with this, I am happy to take any questions.